Thank you very much for inviting me. I'm not really a fellow journalist, but I am the father of a fellow journalist. My daughter is a journalist, so there you go. So maybe one day she'll come here as well. Look, thank you very much for inviting me. I came to this a few years ago, but I haven't been for a while. It's getting a bit sort of latish in the afternoon, and that you're all staring into the sun, or have been staring into the sun. I suspect you're all a bit tired, but anyway, I'll try and keep you entertained. So I'm going to talk about, first of all, what is asthma. You just heard a little bit about what it is. It's a lot about wheezing and a rather unpleasant sensation. First thing, people who know about asthma, who hear about asthma, often want to know is, can you cure it? Or better still, can you prevent people from getting it? And I'll give you an answer to that. And then, if you can't cure it or prevent it, can you actually treat it in any way? Is there any effective treatment? How much of a problem is asthma in communities, in our society? And I'm going to talk to you about a report that's about to be launched at the Union here on this Thursday. So you're going to get a scoop on the Global Asthma Report. I know all about scoops. So what is asthma? Well, it's for people who have asthma. For the people who have asthma, asthma is about symptoms of wheezing and chest tightness, heaviness in the chest, a constricting feeling around the chest. Some people feel as if something's sitting on their chest. People have all sorts of strange terms to describe it, but basically people feel a very uncomfortable constriction in the chest when they get it, and they may have noisy breathing. Sometimes they have a cough. Cough might or might not be an important part of it. It's mainly the difficulty in breathing and the tightness. One of the things that distinguishes asthma from other causes of this sort of breathing problem is that it tends to be episodic. Well, it is episodic. It's not there all the time. Often people with asthma, in between their attacks, are perfectly well. And there are lots of stories of very famous athletes. In fact, I don't know whether it's still the case, but it used to be that most of the Australian Olympic swim team had asthma. So, which is an interesting story. We're not quite sure whether it's because why is such a high proportion of the Olympic swim team have asthma? Has anyone got any good thoughts as to why? Like, it was about 3/4 of the Australian Olympic swim team had asthma. I mean, asthma is common in Australia, but it doesn't exist in 3/4 of the population. Why do you think that 3/4 of the swim team might have asthma? Well, that's one possibility. That's interesting. People didn't really think about that, but it is possible that their swimming caused their asthma. That's one possibility.
How long ago was this? Which team? Like 5 years ago?
Oh, in recent past, I think it's still common in the Australian swim team. Yeah, it's not. It's Ian Thorpe, for example, who's probably the most famous Australian swimmer in recent years, has asthma. Any other suggestions as to why? Well, one reason might be that swimming in swimming pools causes asthma, maybe due to it. But what are other good reasons why it might be? Well, one good reason why it might be is that swimming is a sport that people with asthma can do, whereas they can't do other sports. So it tends to be that when you run, if you have asthma, you trigger symptoms of asthma. Exercising like running and cycling tends to trigger symptoms of asthma, but swimming, where you're exposed to moist air, doesn't tend to trigger symptoms of asthma. So it might be a sort of exercise that you can do, therefore it might be attractive to people with asthma. The other possibility is that people have been, there was a suggestion that not only was it a sport that they could do, but at least it was popular view within Australia, promoted by the Asthma Foundation, that swimming was good for asthma. That swimming, you could cure asthma by swimming. And so people who had asthma as a child used to be sent to do swimming. So there's all sorts of possible reasons for this, and I don't know which is the right answer. I don't think that swimming does in fact cure asthma, though. I think that's very unlikely. Okay, so coming back to what are the symptoms, so it's episodic, it's triggered, so characteristically the thing about asthma symptoms is that there are certain things that trigger the symptoms in individuals, and I'll talk to you about what those sort of triggers are. It's reversible, so what do people do to reverse it? How's it reversed? They take the inhaler, don't they? Take albuterol inhaler, Ventolin inhaler. So I'm supposed to show this slide. We'll see if this works. You can actually see. Is there any sound? It works much better with sound.
There was, yeah, yesterday there was.
Look at his chest moving in and out. Okay, so and you see the
You can see he has quite significant
somebody else is giving a commentary.
coughing and wheezing for 3 days since he had a cold. He is eating and drinking okay. You can see he has quite significant subcostal and intercostal recession,
That's this.
abdominal breathing, and respiratory rate.
See his ribs. Anyway, you can see it's all going in. So I'll show you another one. Try this one.
This 14-year-old boy is a known asthmatic and became wheezy last night. He has never been this bad before. The history came from his dad, as he was too tired to talk himself. He is not distressed, but see how he looks tired. Also notice how he's propping himself up to breathe easier, and he is bobbing up and down with the effort of breathing.
And he's in a very bad way actually. He's at risk of death due to asthma. So asthma can be quite nasty. Alright, and what happens with asthma is that you get these, this is a sort of the airways are the tubes which conduct air in and out of the lungs. In order for breathing to occur, the air has to be moved in and out of the lungs. And they moved in and out through airways, so initially through the windpipe or the trachea, which divides into successive branches, like a tree, an inverted tree, from the big trunk, which is the trachea or the windpipe, out to much smaller branches, which are the smaller branches or the smaller airways, eventually to the leaves, which are the air sacs, where the actual breathing takes place. And what happens in asthma is that those airways, or the branches of the tree that conduct the air, become narrowed and constricted, and often they have a lot of mucus, and they're very inflamed. They're inflamed, irritable, angry, reddened, full of mucus, and twitchy. And that's what an abnormal airway looks like. So the typical features of asthma are those symptoms that I described, the episodic and triggered symptoms. They get narrowing of the airways and airflow obstruction, so they can't blow out as quickly as possible, and you can detect that with breathing tests. And by doing the breathing tests in particular special ways, you can show that the airflow obstruction is variable. It's not the same all the time. It's reversible when you give Ventolin, for example, and it's inducible. If you give something that triggers airway narrowing, you can actually bring on the airway narrowing. So that's the features that are the hallmark of asthma. And also you can do other tests, fairly simple tests on people, that demonstrate that there is inflammation in the airways. So they're the features of asthma. What's the impact on people who have the disease? Well, as you saw in those two videos, and if we'd shown you, they were on children, but you can also see it in adults, that the symptoms can be it causes distress. The symptoms cause distress, both to the person and frankly to the people who are around them. Because it's very frightening, as we just heard. It's frightening to see somebody that you know or love, or your relatives or child, having a bad asthma attack. Very frightening. It's frightening as a doctor, I can tell you, to see somebody having a bad asthma attack. It can cause people to have, during severe attacks, to require to go to hospital, and rarely it can cause people to die. People do die due to asthma during those attacks. And that older boy, I hope he survived, I presume he survived, but that he looked like he was not that, if he hadn't had treatment and if he wasn't in hospital, he was going to die of his asthma from that attack. Also causes you to be disabled, not able to do the normal sorts of things. You can't go to work, you can't study, you can't do household duties, your normal chores, and it makes your sort of quality of life pretty lousy, pretty bad. The other thing is that it needs treatment, and all treatment, and it needs lifelong treatment, and that treatment can have side effects. So, in effect, one of the consequences of having asthma is having to deal with the side effects of the treatment for asthma. So I'll talk to you a bit more about what that is. So it's not only the symptoms of the disease itself, but there's dealing with the adverse effects or the side effects of treatment. What happens to people with asthma? Well, one of the things about asthma is that some people have the view that asthma always starts in childhood. That's actually not the case. We know that asthma can start at any age. It most commonly starts in childhood. So the most common age at which people get asthma is in the first few years of life, in preschool years, before they're age 5. But it can start, and I've seen people who've developed asthma, just like I was showing you in those videos, who are 70 for the first time had asthma. So it can develop at any time in life. Mostly, though, once you get asthma, it doesn't go away. Some young children who have asthma before the age of 5, it does go away. Typically, they are the people who have fairly mild symptoms, don't have a lot of trouble with the disease, and in whom it's not associated with allergy. If it is associated with allergy, or it's more severe, then the asthma tends to persist. And by the time you get to adult age, if you have asthma, it always persists. It doesn't go away, virtually. But although it doesn't go away, it may get better and worse at different times of your life. One of the characteristic times when it can get better or worse, in fact, is when women are pregnant. When women become pregnant, often their asthma gets either better or worse. It's a rather strange thing. And in some cases, people can end up with disease in their later life where instead of getting these episodic symptoms of asthma, where they're well in between the attacks, but they get these attacks of severe breathlessness, instead of that they end up with persisting long-term narrowing of the airways, where they're just breathless all the time. It doesn't go away, they're breathless all the time. And so that can be a problem. In some cases that happens. It's often, I just alluded to allergy, or the other word for allergy is atopy. We often use the word atopy. It's often associated with atopy, and when it's associated with atopy, it's often associated with other diseases, and in particular hay fever or allergic rhinitis. That's sneezing basically, a lot of sneezing and blocked nose, and with eczema, dry, itchy skin, particularly in the skin folds, like in here, and behind the knees, but it can be anywhere. So that's eczema. Eczema and rhinitis and asthma, all three of them tend to be associated with being allergic, and also sometimes with nasal polyps. So what causes asthma? What do you think causes asthma? Anyone know what causes asthma? Tell me if you know, because I don't know. Generally, nobody knows. And generally we don't know what causes. I spent most of my career researching, trying to find out what causes asthma, so if you know, I'd be very interested to hear the answer. But we do know a few things that cause asthma, but just the problem is they're not very common. Most people with asthma, these are not the causes of them. So we know that some people get asthma after they've been exposed to particular things at work. There are certain things chemicals that people work with that tend to cause an allergic type reaction, and they develop asthma. One of the classic ones is something in flour, and so people who work in bakeries, like making biscuits or bread, if they don't have good hygiene practices in the bakery, can sometimes develop asthma. We call that baker's asthma for obvious reasons. And it's something that's in the flour that they become allergic to. There are all sorts of other things. There's things, people who do spray painting of cars. When you when you damage your car and you have to have it painted, and they spray paint. So those paints packs that they use for that contain a chemical called isocyanates, and that's a very potent sensitizer. And if you don't have proper industrial hygiene practices, the people who do it develop asthma. And the whole of other things, sometimes hairdressers develop asthma when exposure to chemicals in the hairdressing salon. People working with soldering, electricians, a number of things. But so, although a lot of things that we know cause asthma in that situation, on the whole, most people who have asthma, that's not the cause. It's a very small proportion of the number of cases of asthma is due to that. We know also that mothers who smoke during pregnancy, when compared to mothers who don't smoke during pregnancy, are more likely to have children who have asthma-like symptoms in early life, particularly in the first few years of life. So smoking during pregnancy tends to do things to the airways of the fetus, of the developing child, that makes it more likely that child will get a wheezing illness. It doesn't seem to be quite the same as the asthma that persists into adult life. So these children are not usually the ones that have severe persistent asthma. But nevertheless, it does cause an asthma-like illness in childhood. So that's another thing you can do, is avoid smoking during pregnancy. So although we don't know what causes asthma generally, we do know a lot of things that make it worse. And we know that the most common thing that causes people who have asthma to get worse symptoms, to get attacks of asthma, to feel worse about their disease, is viral infections. What's the most common viral infection? Well, I've written it there, the common cold. Okay? The most common cold is called common. Why is the common cold called common cold? Because it's common. Okay? So it's a common viral infection. The technical name for it is rhinovirus, but you can call it common cold. Okay? And it's very common, and it commonly causes attacks of worsening asthma. So if you go to an emergency department and see people who've come to the emergency department with attacks of asthma in Sydney, most of them are there because they've had a cold, and the cold has triggered their asthma and made them worse. And they'll usually be worse for a few days to a week, 10 days, and then they'll get better. There are other viruses like the flu that can do it, but they're less common viruses, and therefore they're less common as the causes of the trigger for asthma attacks. So we used to think that there are other things that trigger asthma, but by far the most important one for severe attacks of asthma is viral infections. The next most important one is being exposed to things that you're allergic to. So I mentioned allergic sensitizers in the workplace, but actually most of the allergic sensitizers that we come across are not in the workplace but in the home. And the most common ones are things like house dust mites, cockroach, pollens, molds, fungi, those sorts of things. Biological proteins that people come across that they're allergic to, and exposure to those can make their asthma worse, as well as the occupationals. And then there are other things that don't cause sort of severe attacks of asthma. They don't usually land you in the emergency department with a severe attack of asthma, but they will cause some transient wheezing. And things like exercise. So most people who have asthma, who are not well controlled with their asthma, if they run or cycle or do some sort of strenuous exercise, will induce wheezing. It's usually fairly transient. It might only last 15 minutes to half an hour, and it's usually easily relieved by taking Ventolin, but it will cause some wheezing. So exercise, and by the same means, laughter and rapid breathing. If you breathe rapidly, the mechanism by which exercise causes you to get wheezing is because of the rapid breathing that you do when you exercise. When you exercise, you breathe rapidly and you dry out the airways, and that drying out of the airways triggers the airways to narrow if they're already asthmatic. So all three of those things can trigger episodes of asthma. And then lastly in this list is things that are irritant to the airways, and the common things that people complain of that trigger attacks of asthma. And these act a bit like exercise. They trigger transient symptoms, last for 15-20 minutes, then go away. Things like fly sprays, insect sprays, perfumes, cigarette smoke, some food chemicals, strong smells like that will trigger, that irritate the airways essentially. So those are the things. So we know lots of things that trigger symptoms or cause exacerbations in people with asthma. We just don't know things that cause people to have asthma in the first place. So can asthma be prevented or cured? Well, in general the answer to the question about whether it can be prevented is no. And the reason it can't be prevented is we don't generally know what causes it. Obviously, if we knew what caused it, we might have a chance of being able to prevent it. But without knowing what causes it, we can't really start to prevent it. I did a very large study in Sydney, it's still going on really, where we tried to prevent asthma in children from birth, in a group of children who were at risk of asthma because they had a family history of asthma. And we tried using house dust mite avoidance, an intervention to reduce the children's exposure to house dust mite. And we also tried a dietary intervention because people had thought that fish in the diet might be protective. We tried both those things, and in fact neither of them prevented asthma or allergy in the children. Big study. Well, I'll move on. Can it be cured? Well, it really can't be cured by anything that we know of yet either. So it can't be prevented and it can't be cured. There are some qualifications. Some children do grow out of their asthma, as I said earlier, but we don't know what we can do to encourage them to grow out of their asthma. They either grow out of it or they don't. There's nothing that we can do that will make it more likely that they'll grow out of their asthma. As you can imagine, most parents of children with asthma ask you, the first thing they ask you is, will my child grow out of the asthma? And you say, I don't know. The second thing that they ask you is, what can I do to help my child to grow out of the asthma? And you say, I don't know. And then they say, you're a hopeless doctor, and go and try and find somebody else who will tell them. But what you've told them is the truth. But it can be, even though it can't be cured in the sense that you can take a treatment that will make it go away and you never come back again, it can be controlled in the sense that you can take treatment that, as long as you're taking it, will mean that you don't have symptoms of asthma, for most people. So for most people, this disease can be controlled, but it can't be cured. So in general to that, the answer to that question is yes. But there are some limitations. It can't be controlled in everyone. It requires the right treatment, used regularly, and by regularly means once or twice a day. It requires the treatment to be used by inhalation. You have to inhale it into the lungs. And that's, inhaling treatment into the lungs is not as easy as taking tablets or taking medicine. So there's a bit more of a trick to it. And you need to make sure that you take treatment properly, which is what I mean by it requires effective use of inhaled therapy. And the control, if you like, the fact that the asthma is no longer causing a problem stops almost as soon as you stop taking the regular treatment. Within a couple of weeks of stopping taking the regular treatment, the asthma symptoms will come back again. And it comes at a cost. And that cost is that you have to pay for the medicines, long term, and also, like all treatments, even though these treatments are relatively safe and with very few side effects, all treatments have some adverse effects, and these are not any exception to that. So what do I mean by controlled? I've used this word controlled in the last 3 slides, and what do I mean by it? Well, what I mean by controlled is that basically that the people have few symptoms or no symptoms. Okay, so I told you at the beginning that people with asthma have symptoms of chest tightness, wheeze, heaviness in the chest, cough. So if we can say that a person's asthma is controlled, we're saying that they don't have those symptoms, including that they don't have them when they're exposed to triggers like exercise or cold air or things like that. And they're also that they don't have attacks or exacerbations. They don't get episodes where they have to go to hospital, take more treatment, miss time from school or work. So if they can do all those, and finally that they're breathing, that they don't have narrowing of the airways, that when you measure their lung function is normal. So if they have no symptoms or few symptoms, they're not having exacerbations and their breathing function is normal, then we can say their asthma is controlled. And that can be achieved in most people. This is the only sort of data slide I'm going to show in this talk, but it's a slide from a study that was sponsored by one of the big drug pharma companies, GSK, published 10 years ago now. It was quite a famous study called GOAL. And it shows two different treatment regimens. And the purpose of this slide is not really to show you the difference between these two treatment regimens. What it is to show you that actually that either of these treatment regimens, most of the people who take the treatment are well controlled. So this is a population of people, this is adults in fact, all of whom started out with uncontrolled asthma, all had frequent symptoms or a history of exacerbations or poor lung function. 100% of them or 0% of them were well controlled. And gradually, and then they were started on two different treatment regimens. And they started on two different treatment regimens, and gradually, over a period of several months, they came under control. And between about 2/3 and 3/4 of these people, adults who were poorly controlled with asthma, became well controlled. So that's the good news. But the bad news is what you have to do in order to achieve that, and it's not so easy. Most people with asthma, it requires treatment with inhaled corticosteroid drugs. Inhaled corticosteroids is a class of medications that's the most commonly used class of medications to control asthma. Some people call them controllers or preventers. They're the drugs that are used regularly to control or prevent asthma. If you know people with asthma, you might know these drugs as Becotide or Beclafort or Seretide or Symbicort or Pulmicort or Advair in the United States. A number of different names for these drugs, but their class is known as inhaled corticosteroids. This class of medications, by the way, is not new. It's been around since 1972. It became first available. So how long ago is that? 42 years. It's not a new class of medications. It's been around for a hell of a long time. Okay, but you need to take it once or twice daily. You need to take it correctly, and you need to take it regularly. And in addition to this inhaled steroid, you also usually need some rescue therapy. So even under the ideal conditions, from time to time you will get attacks or episodes of wheezing. And they don't all go away quickly, and they can cause some distress. And you can take rescue therapy, which is Ventolin, essentially. Ventolin, Bricanyl, albuterol, salbutamol, terbutaline, whatever you want to call it. The blue inhaler you take, the rescue inhaler or the reliever inhaler you take when you need it to relieve those symptoms. So they're the two types of inhalers that you need basically to treat the disease. Now I'm going to come back to this inhaled correctly. It's critical that the drug get into the lungs. Yeah.
Is the rescue therapy not corticosteroid based, or is it?
No, it's not corticosteroid based.
What kind of medication is it?
It's beta. It's called it's related some way to adrenaline. It's a derivative of adrenaline, but it's a beta adrenergic agonist. It's a beta adrenergic. It's not related. In the old days, and I mean the really old days, before the 1950s, it was adrenaline that was used. People used to nebulize adrenaline. And it still is it's an effective drug, but it just causes some unpleasant side effects when you take it. So this is a more pure form. This is derived from adrenaline in such a way that it doesn't have the adverse effects of adrenaline, but it has the beneficial effects. Basically, that's what it is. So you need to get the drug into the lungs for it to work, and this is a.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. You're using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
You do have to actually get it into the lungs. So that's the funny side of it. But actually, one of the problems with inhaled steroids is that with this slightly different. With both of the drugs to work, you need to get them into the lungs. As it turns out, the rescue inhaler, the Ventolin type inhaler, it's not very critical how much of it gets down into the lungs. Actually, the amount you need to get into the lungs is only a tiny fraction of the amount that you take with the inhaler. And what doesn't get into the lungs doesn't do you any great harm. With the inhaled steroids, it's different. With inhaled steroids, you actually need to get as much as possible down into the lower airways. And what doesn't get down into the lower airways generally lands in the upper airways, where it doesn't do any good, but it causes a lot of side effects. It causes local side effects, sore throat, thrush, hoarse voice, and also it's absorbed into the bloodstream and causes side effects in the body as a whole. So we want, for the inhaled steroid medication, we want a mechanism for essentially bypassing the mouth and the throat and getting it into the lungs. Well, you can't completely bypass the throat and the lungs because the mouth and the throat come somewhere between. The throat comes somewhere between the mouth and the lungs. It's a bit hard to bypass it. But what you can do is use a device which tends to it sort of channels it down into the lower respiratory tract. It's called a spacer device. So they'll come in all shapes and sizes, but essentially, I haven't got a photograph of it, I should have, but they look a bit like a plastic balloon, like a football, well, like a rugby football, or an Australian rules football. Does anyone know what an Australian rules football looks like? Anyway, like a rugby football. And so you put the inhaler in one end, which sits out here, and you put the other end in your mouth, and you spray into the spacer, and then you suck from the spacer into your mouth. And it has several advantages. One is it helps to coordinate. If you spray the thing directly into your mouth, then lots of people can't coordinate their breathing in with the time at which they spray. Because as you saw actually with that example, when you push the spray, there's a jet comes out. So if you spray it directly into your mouth, you need to get the timing exactly right, so that when you breathe in is when the spray comes out is exactly when you breathe in. And many people can't do that. And what happens is they're breathing out at the time when they spray, and it just goes all through the room. It doesn't get into their lungs. So using a spacer helps to coordinate it. But the other thing it does is a bit more technical. Well, it's a lot more technical, but I'll explain it anyway. What it does is it reduces the momentum of the particles. Does anyone know what momentum is? Anyone remember anything about physics? Momentum is the product of mass and velocity. So when you spray from that thing, particles come out of that with a high velocity, and they're actually quite large particles. And in the spacer, what happens is that these are particles of vapour. In the spacer, they slow down, so they lose velocity, and they actually evaporate slightly, so they lose mass. So in the spacer, they both lose mass and they lose velocity. and therefore they lose momentum. And with less momentum, they're much less likely to go zap into the back of your throat, and much more likely to just be caught up in your breathing in and go down into your lungs. So what the spacer does effectively is help to bypass the throat. So they go, instead of landing in the back of the throat, they go down into the lungs. So it's critically important that people who use these devices use them with a spacer for a number of reasons. So I spent a long time on that. I didn't mean to spend that long. So how well are we doing with all of this? How well are we doing in controlling asthma? Well, the bottom line is we're not doing well. I said this drug has been around for 42 years. It's a long time, but we still have a lot of burden of disease due to asthma, which is unnecessary. Why? I need a water. Why are we not doing very well? Well, there's a whole lot of reasons why people with asthma don't get their disease well controlled. Probably the most common is that no doctor ever prescribes them a controller type medication, inhaled steroid. But even if it is prescribed, it's probably not available. In most countries in the world, it's not easy to get this drug. It is in my country, it may be in your country, but in a lot of countries it's not readily available. If it is available, it's not affordable to most people. They can be quite expensive, and we did a study here at the Union. When I say we, not me personally, but people in the Union did a study and showed in many countries what the cost of 1 month's worth of one inhaler was relative to a nurse's salary. And it was a large proportion of a nurse's salary. So it's just not affordable to a lot of people. So even if it is affordable, it might not be a very good drug. So actually to make this drug properly, it's technically not that simple. And there are a lot of drugs that are marketed that are actually not very good quality assured drugs. So you need to make sure that it's a quality assured drug. There's no point in taking a sort of fake drug or drug that isn't really very effective. So even if it's prescribed, available, affordable and quality assured, many people just don't go and buy it. They can't see the point, they don't understand why they should have it, they just don't go and purchase it. That's common in my country. Even if they do purchase it, often they'll take it for a day or 2 days and then they'll stop taking it. And it doesn't work unless you take it regularly. So they won't be taken. Not taken at all, or not taken regularly, or not taken consistently. Or not taken, as I showed you, it's taken the way that lady in the video took it. Not taken correctly. So there's a whole host of reasons why, even though this drug has been around for 42 years, most people don't get the benefit of it. Very few people really get the benefit of this class of drug. Yep.
What's the difference between asthma and COPD? Because they say in the Philippines, many asthma are being treated as COPD and vice versa. What happens?
Okay, so COPD, it's a good question, and it's a question that not everybody agrees with the answer I'm about to give. I think there is a continuum of abnormality between COPD and asthma. But COPD is really a situation where you have consistently abnormal. The difference between the COPD and the asthma is the episodic nature of it. So patients with asthma have episodic disease, and people with COPD, it's not episodic, it's continuously there. They have narrowing of the airways or reduced breathing capacity all the time. How they get there can be how they get to that state can be as a result of lifelong asthma, but more commonly it's not due to lifelong asthma. More commonly it's due to smoking or due to exposure to some other things. It might be due to exposure to household air pollution, or due to a childhood infection or some other cause. But the most common cause of COPD is smoking. The most common single cause is smoking. But they have the same sorts of symptoms, but they're just not episodic, they're continuous. So they get breathless. So people with severe COPD are breathless on doing minimal exertion, doing minimal tasks all the time.
So, sir, what's your take on traditional medicine? Like they say that seahorse, dried seahorse, if you pulverize it and mix with water, you drink it.
It doesn't. No, I mean the Ventolin, the reliever, the rescue inhaler makes some difference, and for some people, inhaled steroid makes a difference. But the inhalers don't make a huge difference for patients with COPD, and no particular treatments make a huge difference. There are treatments that will work. Some inhalers make some difference, but not a huge difference. Not as much benefit as inhaled steroids do for asthma. Okay, let me come back to asthma, and I'll talk more about COPD a bit later. So what's the consequence of the fact that we're not doing very well? Well, the consequence obviously is that there's a lot of avoidable and unnecessary suffering due to these symptoms, disability, hospitalizations and deaths. Mostly the asthma can be controlled. I've shown you that 2/3 to 3/4 of asthma can be controlled with effective treatment, and yet most people the disease is not controlled, and this is the consequence. So we have a fairly serious situation. Is this common or not common? Well, the answer is it's common. It's not. We're not talking about an unusual situation. This is a common disease, which is commonly not controlled as well as it should be. So there's a lot of avoidable symptoms, hospitalizations, and some deaths due to this disease. This is a slide from a study that was done in the early, it was done in the early 1990s and then done again in the early 2000s. A huge survey done in, I think I put it here, in nearly 800,000 people, children across the world. 800,000 teenagers in 233 centres in 97 countries completed a questionnaire about symptoms of asthma. And bottom line was that on average across the whole world, 14% of children in this age group had symptoms of wheeze in the last 12 months. And that prevalence varied from less than 5% in some places to more than 20% in some other places, particularly in Australia and New Zealand and some Central American and Latin American countries, and in Britain. And then in the same survey they asked about people who had severe asthma. This is people who are having more than 4 attacks of wheeze in the year, who are waking from sleep with symptoms at least once a week, and that's pretty unpleasant when when your asthma's bad enough to wake you from sleep. That's a bad sign. And when you get an episode of wheezing so bad that you can't talk properly, that's also a bad sign. So these are children, now we're talking still 13 to 14 year olds, teenagers, who are getting quite bad attacks of asthma. And here you can see that overall 7% of all children in this enormous population of children across the world have severe asthma. So this is not a trivial problem, this is a common problem and largely treatable. I won't go through it. They did a similar thing in younger children. And then in adults we don't have as good a data from as large a survey, but there is this study, this is a large survey, the World Health Survey, done in 68 countries, and this shows the data on the prevalence of wheeze in all of these countries. So this is divided first of all into low, middle and high income countries. So this on this slide is low income countries, the next slide middle income countries, and the third slide high income countries. Actually there isn't a huge difference in the prevalence across low, middle and high income countries. If you look here, this shows the differences between low, middle and high incomes, and there's not really a big difference. But here we've still got prevalence of wheeze of something around 10-12% prevalence of wheeze in adults. So what I showed you before was children, this is adults. One of the ways, if you've been sort of following anything about the sort of health literature and the burden about outcomes of health, You may have heard of the Global Burden of Disease study. It was published at the end of 2012. Anybody hear about that? The Global Burden of Disease study was a huge international effort to try and quantify the burden of disease in a particular technical way, a way which allowed different diseases and different countries to be compared using quantitatively a measurement which was sort of a common currency, a way in which you can measure asthma against heart disease, against road traffic accidents, against diabetes, against everything else, using a common measure of burden. And there's two ways in which burden is quantified. One is, what effect does it have on premature death? How many people die and how early do they die? How many years of life are lost? That's what YLL stands for. The number of years that are of life that are lost due to premature death due to this disease. So one part of the burden of disease is premature mortality. The other part of the burden of disease is people who don't die but live in a disabled state. So how long do they live with disability and how severe is that disability? Okay, so the years of life disabled is a function of how long was the disability and the severity of the disability. And for every type of disease, it's possible to quantify across the whole world the burden of disease in terms of premature mortality, years of life lost, and disability, years of life disabled. And if you add those two, that's two numbers. You get a number, two numbers. And you add those two numbers up and you get one number, which is what we like to deal with in epidemiology. We like one number to summarise everything. And the one number is called disability adjusted life years, or DALYs. So DALYs is our common currency that we use to quantify the burden of disease due to different diseases. So we can measure the number of DALYs due to asthma, the number of DALYs due to pneumonia, the number of DALYs due to tuberculosis, the number of DALYs due to heart disease, to cancer, and so on. And that's been done. This is a graph which shows the age distribution of the number of disability adjusted life years that are attributable to asthma by age across the whole world. So this is the global distribution by age from children to old people of disability adjusted life years. And the disability adjusted life years here are split into their two components, mortality, premature mortality, and disability, shown here in the blue. And you can see that the biggest burden of asthma occurs in children, where it's a common disease, but mainly causes disability, not deaths. And in older people, where it's also quite common, and it mainly causes premature deaths, but some disability. And it's not evenly distributed across the world. So there are some places where it seems to be more common. The disability adjusted life years attributed to asthma are actually quite common in my country, which is why a lot of people in Australia study asthma. And in the people that live across the ditch here in New Zealand, it's that little country there, it's very common in New Zealand. And it's common in some other countries as well. Actually, it's common in the UK, but it's not that common in, for example, China. It's pretty uncommon in China. And in Vietnam, it seems to be very uncommon. So it does vary quite a bit across the world. The worst outcome that you can have from asthma is when people die. And deaths due to asthma are fortunately fairly rare, but in high-income countries, but not particularly rare in low-income countries. So unfortunately not rare in low-income countries. So these are high-income countries, except this is Qatar and Republic of Korea, which seem to have relatively high asthma death rates. But in many of these low-income countries, and the Philippines is one of them. That's the Philippines there. South Africa. Anybody here from South Africa? Yeah. Sadly, you're right down here. It seems to be quite high. So, anyone from Rodriguez? I have to admit, I don't know where Rodriguez is, but that's the second highest. And then Mauritius. So the thing about asthma that contrasts with many other diseases is that it affects people of all ages. So a lot of diseases principally affect the elderly or principally affect children. Asthma is really a disease that affects people of all ages. It affects the whole world. It's a common chronic disease, and it's the most common chronic disease in children. Much of the variation that we see between countries, we don't understand why it's there. We don't have a lot of data. Now, finally, I'm just going to say a few words about the Global Asthma Report. I mentioned to you this is the scoop, but actually to get the scoop you have to come to this session on Thursday. 1 o'clock in room 128, not far from here. Available from, but it is already available. The report should already be available from the exhibition booth in the exhibition stand, and will in here from the Global Asthma Network booth, and on Thursday it will be available online. So if you just Google Global Asthma Network or Global Asthma Report, you'll see the report from Thursday at 3 o'clock or 1 o'clock. Some of those graphs that I just showed you towards the end were from that, and some of what I've spoken about was in that report. But just to sort of finish up here, I'll just show you some slides from my colleague Ines Asher, who's the chair of the Global Asthma Network, and he'll be launching this on Thursday about the report. This is the front cover of the report. Towards the end of it, it contains a number of... most of the report is a description of the burden of disease due to asthma and the problems of asthma and the approaches to managing asthma, and much of what I've been talking about. But it finishes up with a number of key recommendations which we'd like to promulgate in association with this report. We think are important. And we think they're important because we have with asthma this very common lifelong disease that affects people all around the world and affects people of all ages, and for which much of the burden of disease is avoidable. There is a treatment that's been around for over 40 years which is effective, but which is not being effectively used for a whole long list of reasons that I outlined to you before. Most of those problems can be overcome with adequate attention from governments. So we want asthma. I mentioned to you that asthma medicines are often not available. So the solution to that is to put them on the essential medicines list. So in many countries in the world, and you'll see in that report, there's a list of which countries in the world asthma medicines are on the essential medicines list and which ones they're not. And many countries they're not. So asthma medicines should be added to the essential medicines list, and also they should be. We should make use of the WHO's processes for quality control of medication. That's what this pre-qualification program thing's about. So that they're good quality medication. No point taking inhalers if they're poor quality inhalers. We believe that governments should commit to the research, the intervention and the monitoring that's required to achieve these goals of reducing the burden of asthma. And that requires surveillance and using standardised measures for asthma. So that study that I showed you was last done in more than 10 years ago, and at the moment there's no funding anywhere in the world to do a similar study. So we won't know what's happening, whether it's getting better or worse, because nobody commits funding to it. We believe that governments should include asthma in all their actions arising from the WHO Global Action Plan for Prevention and Control of Non-Communicable Diseases. So when you talk about non-communicable diseases, most people think of heart disease, high blood pressure, diabetes and cancer. But in fact, chronic lung disease, including asthma, is an important non-communicable disease, and we want to make sure that it is included in the NCD agenda. We believe that governments should have a list of essential medicines. I think I've already referred to this. But it should include corticosteroids and bronchodilators. That's the rescue medications that I mentioned. We want them to make sure that they meet good quality medications. We want them to ensure that, as I mentioned earlier in this talk, that one of the reasons that people can't get them is even if they are available, they're often not affordable. So they need to be available and affordable for people with asthma, and they can be made affordable. It's possible. These drugs are now all generic; they're not patented, and they can be made by companies can make them at a cost of $1 or $2, or $3 or $4 anyway per device. So there's no reason why people should be paying $25 or $30 an inhaler, which is what they often are asked to pay. They should only be charging $2 or $3 an inhaler. And if at that price, they're affordable to most people. To many people, not everyone, but most people. Asthma needs to be a health priority. It's been a health priority in Australia since the 1990s, and we have had major gains in asthma control in Australia. It's also a health priority in Finland, for example. So in countries where asthma has been made a health priority by governments, they have made major gains in reducing the burden of this disease. We need to. I mentioned in passing that tobacco smoking during pregnancy is an important issue for childhood asthma. We need to strengthen policies around controlling tobacco smoking during pregnancy in particular. And we want to reduce exposures to harmful chemicals, dust and fumes, which may be contributing to the burden of disease. And they should monitor the costs of asthma. I didn't talk about that, but asthma comes at considerable cost, not only the cost of the medicines, but the cost of lost productivity. This affects people throughout their productive years of life. They often have to miss a lot of work because of the disease, and if not because of the disease in themselves, because of the disease in their children. So often because children are sick, the parents can't go to work, or one of the parents can't go to work. So it causes substantial loss of productivity that is, again, avoidable. I think I probably dealt with most of these. Collect data. We want them to collect good data and report rates of data. I think there's too much here. I'll finish at that point. But so I'll finish there, and I'll be happy to answer any questions, including if you want to ask some more questions about COPD. Yep.
You spoke about side effects of the corticosteroid inhaler. Does the Ventolin have any side effects?
Ventolin itself doesn't generally have any severe side effects. It does have some side effects, but they're fairly transient. So it causes people if you take a lot of it, it causes you to get shaky, tremulous, and it can cause your heart to race a bit, but it doesn't have any severe side effects.
If that's the case, why could a person, if they're having very bad side effects from the corticosteroid inhaler, just use the Ventolin?
No, because the Ventolin doesn't prevent you from dying due to asthma, essentially, and doesn't prevent severe exacerbations of asthma. So the reason people die of asthma generally is because they're only using Ventolin. So most people have access to Ventolin. It's cheap, and most people can use it. And the ones who are only using Ventolin and need to use a lot of it because of their symptoms are uncontrolled, they're the ones who die. If they're taking inhaled steroids, they don't tend to die. There is one other medication that is very important which I didn't mention. That's oral steroid tablets. You can take the steroid. We give inhaled steroids by inhalation as a continuous treatment to prevent severe attacks. But during severe attacks, the sort that land you in hospital or nearly land you in hospital, usually you need to have prednisone, which is a steroid tablet, for a few days in order to get over that bad attack. And that is also widely available and cheap, and often in fact used too much in some countries as a way of controlling this problem. So what happens is that people have an attack, an exacerbation, they go to a hospital, they get a nebulized Ventolin, and they get a course of prednisone. They take that, they feel better, and then 2 weeks later they're back and the same thing's happening again. So unless you take the regular controller type medication with inhaled steroid, you won't solve the problem.
What if your asthma is not so severe? Can you just use Ventolin?
Well, if you're controlled, if your asthma is not so severe, then you're controlled without regular treatment, then you don't need to all you need to be is controlled, as far as we can tell. So if the asthma is controlled, then that's adequate. And whatever it's required, if you don't require enhanced steroids. But as a rule of thumb, if people are needing to use Ventolin for symptoms or getting symptoms more than 2 or 3 times a week, then they need to take the regular controller medication, enhanced steroids. As a rule of thumb, yeah.
How much is the rate of mortality because of asthma? You mentioned before.
Well, they vary a lot from country to country. There was one slide I showed there with it, and I didn't dwell on it, but I can go back to it. It was this slide, I think. So this is the death rates per million population. So we're not talking, in most sort of developed countries, if you like, European, Western countries, the death rate is sort of like 10 per million per year. So it's uncommon. In Australia, just to give you an example, in Australia we have, it's a country of 20 million people. There's 20 million people in Australia, and we have about 400 deaths a year due to asthma. And most of those are in old people. We have about 20 deaths a year in young people. In children, in fact, 20 deaths. Well, no, not in children. Less than that in children. 20 deaths a year in people aged under 35. So death in European countries where the medications are available, it's possible to prevent deaths quite effectively. It's the disability and other burden of disease that's not prevented. But in countries where the drugs are not available at all, deaths are still quite common, and that's what we're seeing down here. So here you've got countries with death rates of 100 per million. So if we had a death rate of 100 per million in Australia, that would mean we would be getting 20 times 100, 2,000 deaths a year. So that would be very different. So it is possible to reduce the death rates, and it varies a lot between countries. Yeah.
Other questions? Would it be true to say that South Africa has the highest mortality rate then in the world?
It looks like it from that figure. That's from WHO's mortality database, 2014 data.
Is that per year?
That's annual.
Annual.
I think that figure will be in this report. So there's your story. It's a good story. If you come from South Africa, not a good story if you don't.
So, Dr. Marks, we are going to forward these slides today to everyone. Can you clarify what they can report today and what is embargoed until you...
Yeah, I'd rather it be, I think it should be embargoed until Thursday.
Okay, so you don't even want them to say...
No, I don't. I think the information about the information about the global asthma report should really be embargoed until Thursday.
Everybody got that? We're not going to report the fact that the global asthma report is being released. Is that what you're saying?
I think you can report the fact that the global asthma report is being released, but I don't want you to report the data in the global asthma report. The first half of what I said about what asthma is, that's not newsworthy, I know, but it tells you the story about what asthma is. The newsworthy part of it you can't report until Thursday, except that the global asthma report is being released.
So when will you be officially released?
At 1 o'clock on Thursday. So then the embargo is finished.
Then we can report.
Yeah, then you can report. Okay, so it's not very long. Just as long as you all. I should have said that at the outset. So I hope you haven't tweeted all this already. Probably you have.
I think you're safe. I can't guarantee it.
Oh, well.
Any other questions or clarifications?
The government isn't going to fall because of it.
One quick question. Can you get, as an adult, smoking-induced asthma?
No, not smoking-induced asthma. What you get is smoking-induced COPD. But in many patients, it looks the same. That's the problem. The disease that is caused by smoking is COPD, and generally they don't have these episodic symptoms. and they don't have reversible or inducible airflow obstruction, they just have fixed airflow obstruction. Generally, that's the rule. What we call asthma is not caused by smoking at all.
But smoking can trigger an asthma.
Well, yes, it can, and particularly, actually, not so much smoking, but exposure to smoke, to other people's smoke, or I suppose your own smoke, but it's inhalation of smoke, yeah.
Probably for a person who has asthma, it's forbidden smoking. Yes?
Well, yeah, for everybody who has anything, who doesn't have anything, smoking is forbidden. That's the point, you see. I don't like to say particular people shouldn't smoke, because if asthma or COPD doesn't get you, cancer or heart disease will get you. So there's no good reason to smoke. Okay, it's the one thing that has no redeeming. There is nothing that smoking does for you that's good, and everything it does for you is bad. Okay, so I think it's a mistake to say that anybody in particular shouldn't smoke. Obviously, if you have asthma, you don't want to get COPD as well. It's not a good idea to have asthma and then smoke and get COPD as well. That isn't a good idea. So clearly it's not a good idea to smoke if you've got asthma. But it's not a good idea to smoke if you haven't got asthma either. That's the point. And I think that's the message. That's the message that I like to get out. And you should get out. People in Georgia need to not smoke. Is that where you come from?
Yes, from
Yeah.
Georgia. I'm a non-smoker person.
I know, but lots of people in your country smoke.
She's quick to say, I do not smoke.
Yes, many teenagers,
Yeah.
unfortunately, many young people are smokers.
Yeah. I think there's lots of good reasons not to. It's important.